All right, so in respect to time, I'm going to get going reading through the beginning introduction here. Welcome, everybody. This is Megan Dotson. I'm the program manager for the National American Indian and Alaska Native Mental Health Technology Center, which is where this event is brought to you by. We have trauma-informed therapy, part 4 today in our learning series. This series is brought to you by our center, and we're part of the National MHTTC network. So this project is supported by SAMHSA, and the content is developed by the presenter, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian and Alaska Native MHTTC. Following today's event, we will send out a follow-up email to which will include links to the presentation slides and recording, information about how to request and receive CEUs, and a link to our evaluation survey called GIPRA. Although we are gathered virtually today again, we want to take the time to acknowledge the land and pay respect to the indigenous nations whose homelands were forcibly taken and inhabited. Please take a moment to read this land acknowledgement, which was created by 3 members of our team, Ella and Keely Driscoll and Sean Bear. This will be included in your handout too. So you're currently muted, but please feel free to use the chat box feature to make any comments or ask questions that you may have at the end. I'm going to let Avis introduce herself. And she's a speaker that has worked with our organization for quite some time. And this series is part of a 6-part series now. So there's just so much content that she has come up with and adapted for you guys. And we want to make sure we get it all in. So we'll be doing another part 5 in June and a part 6 in July. So with that, Avis, I want to let you take over the screen and I'll stop sharing.
Okay. Good morning, probably afternoon for some of you people. As those of you who've been following this series, my name is Avis Garcia, and I am from the Wind River Reservation in Wyoming, and I am a member of the Northern Arapaho tribe. I have a PhD in counselor education and supervision, and I have a master's in counseling and a bachelor's in psychology. And I want to say, I can now say, this is going to age me, I have 2 decades of experience in the substance abuse and mental health counseling field, with a majority of it being with the Native American population where I come from. And this presentation today is a continuation of the brain-based therapies, interventions to use after trauma with patients. And throughout the years of my experience, I want to say my very first job as an addictions therapist, I discovered from day one that I would say anywhere from 75 to 80% of our clients coming into treatment, mainly residential treatment, because usually they get into substance abuse really heavily and don't get help until it's too late. So I focused a lot on trauma, and even more so while I was in my doctorate program, because I watch a lot of Dr. Phil, and I'm just fascinated with Dr. Amen, who comes on as someone who specializes in the brain, treating the brain, but they have access to technology that I don't know that I'll ever have access to, but I find it really fascinating that through therapy and other interventions that we can change our brain, we can get better. It's just doing things differently. So I am going to get to the screen sharing. Okay, for some reason it says the host disabled the screen sharing.
1 second, Avis.
Okay.
Okay, try now.
Okay, there we go. Can you guys see that?
Not yet.
Okay. 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 Okay, I don't know what we did here. Minimize that. Clicking share. Okay, can you guys see that now?
Yes, we can. It's just
Okay.
me though, so we don't want to see that.
What's that? Okay, are we good now?
We are.
Yay. Okay.
Let's
Sorry,
try.
guys. I had trouble connecting from the very beginning, so we will get started. And I need to fast forward this to where we left off. I apologize. Yeah, when I got into this, I was like, there's just so much of this. I can go on for hours. And some of this comes from training that I've had throughout my life. And sorry, let me get to the right page. Let's move right along. And I'll be sending you guys the correct version of the slides that I have here. Okay. For some reason I am missing one. I apologize, guys. Okay, and now I may have pulled up the wrong slides again. I thought I sent the right ones, but this doesn't look like it. Okay. Okay, page, let me find the right slide. Here we go, here we go. Okay. Okay, here we are. Sorry. Okay, the first time I did this first half of this presentation on the brain-based trauma therapy and strategies, you had asked for assessments. So I have already sent all of the assessment information to Megan. And when they send these slides out to you, everything that I'm going to refer to here in this presentation is going to be attached. And a lot of these are free resources, and some of them are from my training. And I am a clinically, I am a trained clinical trauma therapist. And like I said, it's come from my interest in this work and realizing that there was a need to do it. So most of the responses are brief. Some of the tools that I have are brief and can be covered quickly. I suggest that the client share what they're comfortable disclosing, because some clients aren't even comfortable disclosing, or they're so traumatized that they're in a condition not to be able to disclose. So I'll get into some of those that are difficult to treat a little bit later, because I'm not qualified for those. So oftentimes I do encounter people that are very difficult to treat, and I have to find a referral for them. And okay, we always want to pay attention to our clients to see if they're having any suicidal or homicidal ideation. And I ask when and what precipitated it. So what might have led them to where they are right now. And again, some of them will deny that they have any suicidal ideation. So I always suggest that they have a supportive network to monitor them when they are struggling with trauma in their life. A recent study by Rudd in 2011 found about half of military veterans in college admitted suicidal ideation. 20% had a plan, 4 admitted a failed suicide attempt, and this is a significant study, and it is a non-clinical group. It's important to check for the need of medication, family involvement, more sessions or more treatment or hospitalization. So we need to know if any prior counseling has been helpful. What is the presenting problem? Did they get a diagnosis? Who did the counseling? When did it occur? And if you're trained or experienced, you must be prepared to, if you're not trained, like I said, you need to refer to the appropriate professional. So the presentation that I'm doing today is actually for advanced clinicians. So those of you that are new, are helpers in the field, this is educational information so that you'll know more about what treatment services you can refer some of the patients to that you're working with. Okay, some trauma-related risk factors. If the client reports that they have experienced trauma of any kind, it's valuable to explore the risk factors more in depth. If a client comments, there are years of my childhood that are a blur, I don't remember that much about it, I'll explore possible depression or disassociation. So either one of those are coping mechanisms that they use, as our brains are basically made to help us survive. So that's how the brain functions on its own. Some use risk factors to pinpoint. Age, how old were you when the trauma occurred? Gender, do you think of yourself as having a voice when you grew up? Did you feel special in your family, or were you respected? The temperament, observe the client's emotionality relating to his or her story. When growing up, did your family say you were too emotional or too sensitive? Because some are. Family genetics and history. Ask the client if any family member has had depression, anxiety, mood swings, or alcohol or drug abuse problems. Oftentimes, a genogram can be helpful to identify this. You want to explore to learn of early loss of the parent through death or divorce. These are the people who are more at risk for depression or anxiety as an adult. Get a sense of the family's resources, emotional, financial, ask where the client went to school and what were their significant experiences were there. Any child abuse or neglect. Clients who were abused may, upon entering counseling, admit their abuse in childhood. Others minimize it. Others might not remember because they moved on successfully, or they have disassociated the memories. Because if you recall, I did tell you there are some very resilient people that are not going to be severely traumatized. So not everyone has serious problems with this issue. I ask how they were abused and by who. I ask how they were impacted by the abuse. Some say they vowed they would never physically discipline their children. Others minimize the impact of the abuse, although they were referred for anger management or domestic violence. I ask if they have ever considered their issues with anger could be connected with their own parents' heavy-handed discipline. If a client admits sexual abuse, I ask if they'd be comfortable with a few questions. Some are open and some say it depends on the questions I share. I don't want to move too quickly, then they're ready for. But if they can tell me, I respect their right to answer any of my questions. I do not encourage a full, detailed exploration of the abuse during their initial assessment. So that covers that. Prior psychological problems. Depression and anxiety onset to trauma are predisposing factors to the development of PTSD. Such has been found to be true of crime victims, soldiers in combat, and victims of natural disasters. So those that already have had this mood disorder are more prone to going into full-blown PTSD. So we want to explore those PTSD symptoms. As the client tells their story, as they all have a story, the counselor hears the trauma that led the client to enter treatment, or the client admits to a history of trauma when asked. A third group of clients exhibit behaviors which suggest possible trauma, such as defensiveness when asked about trauma or abuse, intrusive experiences or periods of amnesia not related to head trauma. The counselor is wise to explore possible PTSD symptoms with all of the above? Okay, do they have any flashbacks? Do they have any upsetting nightmares? Do they experience other dissociative reactions, losing awareness of the present? Do they experience emotional or physical distress as a reminder of the trauma? And if the client experiences one or more of these symptoms, that would be indicative of PTSD. Hyperarousal. Do they have difficulty going to sleep or staying asleep? Do they have troubling nightmares? Do they react intensely when startled? Some people, it's loud noises or fireworks on the 4th of July. Do they have difficulty concentrating when attempting to focus? For example, when reading or at work? Do they tend to be vigilant for signs of danger when others would see the situation as neutral? Do they tend to be irritable or have angry outbursts? It is valuable to explore with clients whether and to what extent they experience symptoms suggesting an overactive sympathetic nervous system. DSM-5 requires 2 or more of the above symptoms to confirm hyperarousal. When working with traumatized children, it is often important to involve the parents, at least in the assessment phase. And then we have the avoidance of triggers. Sorry, I'm trying to. The avoidance of triggers are efforts to avoid thoughts, feelings, or conversations about trauma, efforts to avoid places, people, activities that remind them of it, an inability to recall an important aspect of the trauma which is not due to a traumatic brain injury, diminished interest in significant activities, feelings of detachment or estrangement from others, restricted range of affect, for example, not having no affection. When clients are easily triggered to have some stress reactions to their trauma as well as to any person, place, or thing that reminds them of the trauma, their ability to express softer feelings or be emotionally close to others is diminished. The DSM-5 lists all of these symptoms above. Depression and helplessness predicts suicidal ideation, but the following factors were seen as the best predictors of suicide attempts. We have PTSD, a history of sexual abuse, anxiety, drug or alcohol abuse, lack of education or low level of education. And again, this doesn't mean everybody is going to have that problem. And then gender. Men are more at risk for that. Children are adults who have been traumatized and who did not receive validation and support from family or friends soon after their traumatic incident are more likely to develop PTSD symptoms. Intensive experiences, hyperarousal or hypoarousal, may make them feel out of control. They may say things such as, I feel like I'm losing my mind. They may feel some stigma about seeking out mental health services, especially among military veterans, because these are men. Most of them are not willing to go seek help, and less educated males and minorities make these groups more likely to ask for professional assistance. Poor problem-solving skills, emotional dysregulation, Black or white thinking make them at a much higher risk to see death as the only answer to their pain. Assessing low income and minority clients. I mean, I think that is us. We all fall in that. I grew up on the reservation and I never even realized that I grew up in poverty because everybody else around me was living the same kind of lifestyle as I was. And it didn't really appear to me that was where I came from until I got into college and learned more about the socioeconomic status. So we want to look at financial stress. Are there any collections, unemployment, or did they just lose their job? Housing instability, frequent moves, and homelessness. So where I'm living right now off the reservation here in Cheyenne, Wyoming, I want to say I never realized there were so many homeless people in Wyoming. And a majority of these homeless people are suffering from severe trauma. Is there any family instability, divorce, abandonment, or jail? Poor medical care, food insecurity. Are they hungry? We need, was there a dearth of fruits and vegetables? Parents may be less educated, less reading, more TV. Parents may be less nurturing. And this is not to say that this is how we all are. So if you attend my last session on intergenerational trauma, I'll get more into the specifics of Native Americans' trauma that has been handed down. Parents with mental health issues, and I have met people who have struggled because of their parents with mental health issues. And the presence of adverse childhood events. This is the ACEs. And I like to use the ACEs as, one of my group sessions, because a lot of people will really start to open up about experiences they've had in their life. And it's good for them to know that they're not alone and there's other people who relate to how they feel. Okay. There are those who are disadvantaged for years or generations, and they're at risk for increased stress and impaired development. These risks are common to many low-income families that I listed above. Too many disadvantages impacts clients negatively, both immediately and long-term. They may have poor sleep due to trauma, stress, poor supervision, health issues such as diabetes and obesity, weak executive skills, meaning they have poor attention, memory, and self-regulation, delayed cognitive development, mental health issues, and low educational achievement. If neither parent has a steady job, or if one parent has a low-income job, the family will have financial stress. Calls from collection agencies and frequent moves are likely. Couples in such a situation are stressed and often conflicted. One or both parents are likely to be depressed, anxious, or angry, and are angry. One may have drinking or a drug problem. Separations or divorce are likely. Children in such families are likely to be chronically stressed and or experience learned helplessness. They may cope by giving up or having an angry defiance. Stress is cumulative. Imagine a woman who is raising her two children alone or on a low-income job. The father of her children is in jail. She was raped at 14 by an older neighbor. 60% of inner city Black girls are sexually assaulted before they reach the age of 18. She is hassled frequently by bill collectors because she's behind on paying her bills. Now imagine she's assaulted by her new boyfriend. She is at a high risk for depression and PTSD. Her sense of helplessness is easily understood. Minorities with low incomes are more likely to be harassed by police or to be targets for racial hostility. They are also at risk for being victims of job discrimination and neighborhood violence. First and second generation immigrants from Europe, Asia, or Africa experience stresses of adjusting to a new culture and often new language difficulties with English, and unemployment creates stress for some families. Conflict between cultural values of the old and new play out of conflict between the generations. Some immigrants come from war-ravaged countries and have PTSD when they arrive here. The LGBTQ youth and young adults have a wide variety of stresses, both internal and external. They may be struggling with identity confusion or internalized homophobia. Research documents that LGBTQ are frequently harassed, bullied, or even assaulted by peers. LGBTQ adults are also targets for hatred, and they are more often physically or sexually assaulted than their heterosexual or cisgender peers. They are at a higher risk for PTSD. especially if they are not supported by their families due to a religious bias or homophobia. Identifying strengths. It's important to explore the client's inner and external resources they bring. How connected are they to friends and family? Do they have an ongoing relationship with a supportive parent or sibling, which can mean the difference between life and death? A few close friends can be a great resource for anyone when clients are feeling overwhelmed. Isolation is a symptom of both depression and a broken family. Some external resources. Social groups can be very helpful, such as a church, a basketball league, cultural groups, a book club. Watch for the yes buts. Black or white thinking is an enemy of emotional health. Seeing all good or all bad means they are at a risk for impaired relationships and severe depression. Clients who see shades of gray have more options and more possible solutions. The ability to maintain optimism is a huge plus. When clients are isolated, I ask them about a close friend from the past or a new interest they would like to develop that would involve other people. Cognitive flexibility makes possible looking at a situation differently, or looking for out-of-the-box solutions. Whether one can still see humor even in difficult times can greatly affect one's ability to move on rather than stay stuck. We take problem-solving skills for granted. Clients must be able to solve problems in order to be able to pay their bills and keep a roof over their head. Yet some individuals have not learned to solve interpersonal problems. They dominate and submit, or they blow up and don't talk about it. Assessing how clients resolve conflict can be helpful in individuals as well in relationship counseling. Physical health. Regular exercise is very important for mental health. This doesn't mean you have to go exercise for 3 or 4 hours every single day of the week. If you can get out for 30 minutes, 3 or 4 times a week is plenty. And it doesn't have to be done all at once. Some people might take a walk during a morning break, a lunch break, and maybe afternoon or evening break. So there's creative ways of squeezing some exercise into your lifestyle. It is helpful to know how often clients exercise and what they do. Are they getting enough? If they are not exercising, you can ask what the client has enjoyed or benefited from in the past. Maybe they played basketball, or they were a track person, did cross country. It's recommended that we do at least 150 minutes of easy to moderate exertion each week. So like I said, it doesn't have to be real extensive. High-risk behavior is valuable information. Has there been any reckless driving, any drug abuse? Are they living in a high crime area? Is the client usually safe, or does he or she pursue adrenaline rush activities? Finally, learning how clients understand the big questions can be critical. Do they participate in an organized religion or participate in cultural traditions? Do they have an understanding of life that helps them make some sense of the tragedies they experience? Do those who see no meaning are more at risk in depressing periods of their life? On to case conceptualization. The old stereotypes of analysts was that they listened and nodded their heads for 50 minutes, made one or more brief comments, and set the next appointment. Today, clients want to hear how we make sense of their story and hope that we empathize with and validate their pain. It's important that use of narrative therapy acknowledges the importance of stories people tell us about their lives. Narrative therapy, we all have a story, and I really like this for work with Native American people because historically, we are storytellers. As nomadic people, we were not able to carry textbooks with us and tablets. We relied on story. A lot of our learning was passed on through oral tradition. For example, a traumatized woman as a young child by her father's sexual abuse is unlikely to be coherent because parts of her memory has been disassociated. She is likely to feel ashamed, responsible, and victimized simultaneously. The goal of narrative therapy is first to articulate and empathize with the story the client brings to counseling, and over time to help them develop a new story, to change it to a new positive story. The client is no longer primarily a victim, but now a survivor, and even better, a teacher of important truths to pass on. And I apologize for these typos. I don't even see them until I actually start doing these presentations. So if you want to use these and fix those, you can. We have to be mindful of what is passed on to the next generation. The words we use in our summaries of our first two assessment sessions matter a great deal. We use the client's own words and mirror the client's feelings. We identify connections that the client sees. We carefully raise the possibility of other connections, avoid getting too far ahead of the client. Sometimes the client's story involves recent trauma, and the client or family member is able to connect the dots with a new effect. And going on to the APA website, after the session summary, it is natural to seg to treatment planning. So after we've gotten all of the information, we will want to look at what are we going to do to help this person get better or learn some effective coping skills so that they can manage to get on with their life. Brief treatment would be our approach and would include normalizing their fear, teaching relaxation, and using exposure technique. Imagine the accident and let go of the fear. Being knowledgeable about current treatment research is essential for competent ethical practice. So if you do some Googling, you'll find some trauma organizations that you can be a part of, that you can get regular emails of information from. Knowing whom to refer a client where problems are outside our area of competence is important. And right here is a website that you can assess and get more information. If major depression is a history of multiple episodes, you would want to discuss counseling and medication as options. And oftentimes medication doesn't have to be long-term. Sometimes it could be temporary. And when I know more than one treatment for a given problem and both have strong research support, I describe them to the client and ask which one they'd like to try. For example, some with PTSD may benefit from EMDR, cognitive processing, or prolonged exposure. I give a brief explanation for each treatment and offer more information if the client desires that. Clients who get to choose their treatment are more likely to be committed using it in their own life. So it's person-centered when we give the patient the option to pick what it is they're willing to participate in. Process issues in trauma work. It's important to keep in mind that safety is important and that we are to do no harm. All providers know their first process is to make the counseling room a safe place. So we need to make it comfortable. I had a girl that had a psychiatric disorder that caused her to have visual hallucinations. So we had to fix the room just right so that there weren't any shadows coming from the window because it would scare her. All providers know their first process. Okay, the room temperature needs to be comfortable. We don't want it too hot or too cold. You might want to have some throws handy in case they need to, feel safe covering up. We don't want any harsh lighting, and we don't want to be bothered by phone calls or knocks on the door. And make the counseling safe. It involves much more than a pleasant room and avoiding inappropriate acting out. Some other interventions should focus on stabilization. on the development of affect regulation skills. So teaching them how to handle anxiety, how to handle some depressive feelings. High functioning clients reacting to a single recent trauma may spend a little therapy time learning some relaxation, some calming self-talk, reaching out to friends when they're distressed because they already have these skills and they can refine them very easily. So these are more resilient people. Clients with complex PTSD may need a year or more of work on distress tolerance and affect regulation before confronting their trauma. So some of these people may not be ready to get right to work and may need extensive therapy. So if you're interested in DBT, Marcia Linehan is the person who's well known for that. That's the dialectical behavior therapy. Cognitive processing therapy. This is the one that I really like and I think is one of the very best. And if clients are ready to discuss the trauma in any detail, they may be good candidates for this cognitive processing therapy without the written account of trauma. The option can be just as effective for many clients as more emotionally demanding treatment, such as prolonged exposure. I'm not a big fan of the prolonged exposure. I don't specialize in it. Some do, but I just thought I'd mention it for those that might be interested. It necessitates making an extended account of the trauma and revisiting it multiple times a week during the most intense part of treatment. Most clients can be treated safely if exposure to trauma is not required. Treating more fragile clients, be mindful of the intensity control of the session. When doing exposure work, it is important that we begin the session and end in a more relaxed mode while the intensity be higher in the mid-session. So you need to be watching the clock and also knowing where we are. We don't want to get the person so worked up that we can't bring them out of it. So we may need to tell them, okay, let's stop right there. And when we come back, we'll pick up right where we left off. And so then we can focus on helping them come down and calming themselves down to get ready to exit the session. Some clients may need longer than 50 minutes, hour, to confront some aspect of their trauma and return to a calm equilibrium. Generally, most individual therapy sessions are 50 minutes. I use the last 10, write your note, get it done. You have it documented and go on. When using Siegel's mindful approach, it will complement the above strategy. When professionals can track the arousal level of their clients, feeling that their clients feel can modulate the intensity of the session and keep it in the safe range. So if you're paying attention to your own reaction, you'll start to feel when you might get a little worked up about it. I've included in the handouts a window of tolerance handout. So when you get those handouts, that's a good one to take a look at. In an effort to save time and squeeze a lot more information into this presentation, I just attached that for you guys to use. And then always in any kind of counseling, we need to be mindful of transference and countertransference. Are they putting something onto us? Are they causing some feelings to arise in us? To be mindful of that when we need supervision for ourselves and some follow-up. Clients with complex PTSD are more likely to provoke countertransference. Reactions that, if not handled carefully, can be disruptive to the counseling process. Again, like I said, self-awareness is critical to the professionals not acting out. More importantly, self-awareness can enable the professional to feel some of what the client felt during or after the abuse. Dialectical behavior, again, is by Marcia Linehan, and she has written a detailed account of recommendations to how to intervene with clients interfering therapy interfering behaviors. DBT is a developed unique treatment approach integrating mindfulness from Eastern spirituality to cognitive behavioral strategies. DBT fuses a technology of acceptance with technology of change. The primary target of DBT is reducing suicidal and parasuicidal behavior, or the secondary target is focused on reducing therapy interfering behaviors. Linehan developed her program working with women who intentionally injured themselves. In some way, they were transported to some of these will be transported to an emergency room, and many of these women are diagnosed with borderline personality disorders and their difficulties with respecting boundaries. So these could be the people that may have some inappropriate behaviors in sessions. So it's always good to have a experienced supervisor on hand to be able to consult with them if you feel like you might be dealing with somebody who has some difficult behaviors that will be interfering with your trying to work with these people. Linehan categorizes therapy interfering behaviors this way. And these are some of behaviors that interfere with them getting the therapy that they need. So they may be non-attentive, they might miss sessions, walk out of sessions early, fall asleep, or daydream. And it makes it challenging because this is, I see from my perspective, as a way of avoiding getting into it. They just don't even want to go there. So they have to be reminded that we're seeing these things, and that if we're going to help them, we need to be able to focus on them being open. The non-collaborative behaviors, not speaking in sessions, or answering I don't know to all the questions, and withdrawing emotionally in the sessions. Non-compliant behaviors such as arguing constantly, not completing homework, or refusing to follow treatment recommendations. And like I said, this is just how they've learned to cope. And it may be important to point that out to them, that you understand why they might be behaving the way they are. And there's the behaviors that can burn out therapists. So we also need to monitor ourselves that we don't put ourselves in this position. Pushing the therapist, personal limits, phoning too much, going to the therapist's home, initiating interaction with the therapist's family members, demanding solutions to problems that are out of the client's or therapist's control, demanding more time than the therapist can offer, behaving provocatively or seductively, and this can be common from sexually abused clients, threatening to harm the therapist or her family, and pushing organizational limits, load ratios, guns, and intruding on others' offices. So when we talk about load ratios, some agencies are such money-making machines. They are more focused on loading the therapist up with clients up to 30 hours a week. And I personally, if I'm supervising the staff that I work with, I try to keep them at 20, because I believe we want to provide quality services. And again, like I said, working with trauma can take 90 minutes. So if you're going to do some trauma work, you want to give enough time to be able to work with that person, because once you get going, that 60 minutes will go very fast. Another one is behaviors that decrease the therapist's motivation would be chronic hostility, demeaning the therapist's efforts of this doesn't make any sense, this isn't doing any, you don't even know what you're doing. Personal criticisms of the therapist, denial of progress when something has occurred, and threats to sue the therapist or report the therapist to the licensing board. So we need to be very careful when we work, not with just trauma clients, but anybody. DBT, this is the dialectical behavior therapy. This is a new treatment intervention, and there is a DBT book for working with substance use disorders, and I don't have it, but if you Google it, it looks like it has a seashell on the cover. Very excellent book for any of you doing any substance abuse work, because I like how it gets the clients to understand and learn and express their feelings. So for a lot of the clients that we work with, they just haven't learned how to express feelings. And we've grown up in home environments where we weren't taught that either. So a lot of what I've learned has come through my ongoing education. Clients may engage in any of the above behaviors from that slide before from time to time. DBT is where the professional is given concrete tools to use with the client to discuss and hopefully reduce negative behaviors. Linehan also details therapy interfering behaviors that the professional may display. So we also need to be looking at ourselves. Could we be interfering with this? All the acting out or passive aggressive behavior is not assumed to be the province only of the client. So again, being mindful of our own behavior that we're displaying in session. DBT clients are informed at the outset of therapy what behaviors will increase or reduce the likelihood of the success of treatment. So we need to remind them how important it is to be on time, how important it is not to miss a session unless they absolutely have to. I sometimes tell them it's kind of like opening Pandora's box, and we don't want you to go out into the world with that box wide open and not be able to know how to shut it. So it's important to be able to continue their work, because if they don't come, sometimes it's like starting all over again and you have to back up and start over again, because it has to kind of follow a sequential format. Then there is the 3-step process of DBT. We need to identify the negative behavior as clearly as possible, avoid language suggesting a character deficit, conduct a chain analysis of the behavior. What were the internal and external antecedents or triggers, and what are the consequences? And so I often do what most people know as mind mapping, where you draw the one problem in the middle, like they're not showing up for their sessions. So then we can just draw lines off of that. So what's going on there? What's causing this? And help them develop a plan to reduce the negative behavior. DBT encourages counselors and clients to live in a dialectic paradox. Clients are doing the best they can, and clients do want to get better. The best attitudes to have with acting out clients are to accept them as they are and encourage them to grow in using their positive coping skills. Most of the clients are committed to the process and agree to use the plan to reduce the behavior. Occasionally, we'll have a client who refuses to do it. If the therapy interfering behavior is significantly disruptive, the provider may review with the client how the negative behavior gets in the way of them reaching their overall treatment goals, which is to get better. If the approach isn't successful, the client is offered a vacation from treatment or a referral to another provider, and develop a plan collaboratively with the client to deal better with any underlying issues. So sometimes we're just not that person for that person. And I have had women that don't want to work with a male because, their trauma involved a male. So we need to be mindful of, maybe you're not working well with that person and we just need to get someone different. And most clients, again, like I said, are committed to the process and agree to reduce the behavior. And I think I've already covered that. So we'll skip on to the self-awareness. Again, we need to be aware of our own feelings of fear, sadness, anger, or helplessness. Self-awareness in the moment can lead to better attunement with the client and his or her pain. So they are going to trigger some reactions in us, but if we learn and have a good supervisor while we do this kind of work, it'll be really helpful so that you know how to take care of yourself, because self-care is number one in doing trauma work. It's something you have to do all the time, not just every once in a while. Using DBT to therapy interviewing behavior, do a behavioral analysis of the antecedents and consequence, and develop a plan collaboratively with the client to better deal with the underlying issues. So whatever it is that's causing them to behave the way they are, maybe we can discuss that. Maybe somebody's telling them some stories that aren't true, and maybe discouraging them to share any information because they feel like it's going to expose their family. Time-limited treatment of PTSD can be brief and intermediate length of treatment of clients includes normalizing their symptoms. This is a perfectly normal reaction to the situation that you're in, and that's how I put it out there to them. And teaching them some ways to calm themselves. This session will describe the components of EMDR, cognitive processing therapy, and bottom-up treatment. It's also critical to address comorbid disorders such as major depression and substance abuse. So a lot of times we got people with 3, 4, 5 diagnoses on their evaluation report. So it's good to be paying attention to that. At this point, the counselor has hopefully developed a positive alliance with the client and has fully assessed the client's current symptoms, risk factors, and resilience. The therapist has summarized what they learned and has offered individual counseling focused on healing as the next option. Or the client may be referred to a provider who offers trauma therapy. I personally do not do EMDR. I have the training purchased. I just need to get in it, and it is a long term training that involves you doing more follow-up with the supervisor on a regular basis, so they don't just say, okay, now you know EMDR and you can go out on your own. So I've done a lot of research and reading on it just so that I can share the information with the client, because I know who all offers EMDR in the town that I'm in. And the state of Wyoming, about, I want to say 2 years ago, actually paid for several people to get this training for free. And unfortunately, I wasn't one of them, but I do know some of those that got it. So it's important to find those resources in your community so that you have a go-to person for the people that you think this might be beneficial for. And a client desiring medication would need to be referred to their family physician or to a psychiatrist. The therapist has described the treatment approaches that they offer, so I can share with them what I can do. And if they would like to proceed, then we'll go that route. And if they want to go be referred to another person, I will make those arrangements for that to happen for them. Okay, phase 1 of PTSD focuses on psychoeducation and stabilization. Clients with trauma symptoms tend to feel like they're crazy, overwhelmed, and out of control, are numb. Clients tend to relax some and gain some sense of hope when their provider makes sense of their symptoms. So when you can show them, I'm seeing this, this, and this, but this is what PTSD is, and it's often a result from some trauma that they've encountered in their life, either recent or in the past. So we want to normalize their symptoms because it'll help them feel like they're not crazy. Post-traumatic symptoms are normal ways that our mind deals with stress. So that's just the brain doing its natural thing. Some intrusive events include flashbacks, obsessions, and nightmares. Again, this is the mind's attempt to understand the trauma. Sometimes the mind pushes everything aside, overwhelming experiences as too intense to integrate at the time. So the mind just like, we'll deal with that later. Let's put that on the back burner. With help, the client can put all of these pieces together and develop a coherent story of what happened so that moving on is possible. Numbing is the opposite reaction. The mind needs a break from the intensity of the feeling around trauma. And they might say something like this: sometimes I don't feel anything at all. Avoiding traumatic cues involves keeping away from the situations that provoke post-traumatic fear responses. An Iraqi veteran may avoid particular roads, crowds, or events with fireworks. A rape victim may avoid the locale where she was victimized. Some women may become agoraphobic and stay inside and stay home and stay away from everybody just to avoid contact with any stranger because they're that affected. Hyperarousal may include frequent intense anxiety, fear, or anger. It frequently results in an exaggerated startle response. Traumatized individuals are easily provoked to have intense reactions, and their alarm system is easily set off. Phase 1. All of the treatment of PTSD focuses on psychoeducation and stabilization. So when I say psychoeducation, we're providing some education to them so that they understand what are the causes and what are the treatments so that they can get some education on the problem they may be struggling with at the time. And stabilization. Clients with trauma symptoms tend to feel crazy and out of control or numb. Some tend to relax and tend to gain some help when their provider helps them make sense of their symptoms and normalizing the symptoms. And again, this is just a normal way to deal with overwhelming stress. Drug or alcohol use frequently occurs with post-traumatic reactions. The client is trying to soften the intrusive events and the hyperarousal or feelings of numbness. Depression is often experienced by those who have been traumatized. They may be stuck in feelings of helplessness or self-blame. They may be grieving important losses, such as they lost a friend, or of their own health. Maybe they're losing their vision or their hearing, or they've lost their ability to walk because of a serious car accident, or their own innocence, trust, and sense of control in the world. So they may just feel like they aren't able to handle a lot of things. So phase 2 and treatment involves exposure to the trauma and avoiding situations and our cognitive restructuring. Multiple research studies have found EMDR and CPT, cognitive processing therapy, to be effective treatments for clients. Other effective treatments for trauma are listed in this website that I posted here. In order to save time, I've just posted that there for those who are interested in doing a little more research on their own. High-risk behaviors become the refuge of some of our survivors. They may be addicted to the highs of combat and killing. They may speed excessively, use amphetamines with their friends, or seek out some high-risk situations. Some high-risk sex is a way to cope for some survivors of rape and sexual abuse. It is a way to escape their own pain, even if it's only brief. Symptoms are the mind's way to survive. They make sense, but they can diminish as the healing process proceeds. Many clients benefit from self-help books and explain that PTSD symptoms and ways to heal. And this website has some really excellent information that can be helpful. EMDR, we'll talk a little bit about EMDR. And this was developed by Francine Shapiro in 1995 through her work with traumatized Vietnam veterans. And they saw clients who were stuck in the past, using dysfunctional means to cope with anxiety and or depression, which often includes excessive drug or alcohol use. Analytic treatment encouraged talking through the trauma again and again if needed. So talking about it more than once, and giving expression to the memories and pain to become free and live a normal life again. Sometimes this was successful. Some clients verbalizing the trauma can re-traumatize the client and make them even more fearful. So we need to be careful of that. EMDR encourages the client to process the trauma while splitting their attention. Part focuses on trauma in the past, part focuses on following the active bilateral situation in the present. So we want to look at how the brain, both sides of the brain, are dealing with this. This bilateral stimulation is used to involve both hemispheres of the brain. The treatment has moved to having the client tap both knees or listen to music, bilateral in both of the ears as alternatives to the therapist's finger movements. So the EMDR may have them imagining a situation that they're in, and they do this waving of the fingers back and forth. And then some of them have different tools. I had a supervisor who actually had this light bar in her office. So the light bar would go back and forth so they would follow the bar. And there are some new equipment, but like I said, I am not trained in this. I know people that do it. I ask a lot of questions because I'm very fascinated with it. The key is that the client returns to the scene of the trauma while simultaneously attending to the bilateral stimulation. The client need not verbalize the details of what happened, but just as long as they can imagine that while this is happening. And it will also reduce the likelihood of re-traumatization if they don't speak about it while this process is taking place. Okay. EMDR phases. There are 8 phases of the EMDR. The first is taking the history, preparing them for EMDR. This is what it's all about. Assessment of negative cognitions, painful emotions, and body sensations. Where are they feeling? You know, when they get these intense reactions, where are they feeling it in their body? We want to look at desensitizing and reprocessing, so making them less sensitive to it and re-going through some of that trauma. And installation of positive cognitions. So we want to change a lot of what their thinking is and make it more positive. And 6 is a body scan to detect residual discomfort. 7 is closure of the session, and 8 may be a reevaluation. Maybe we need to go back and do another round of this EMDR. In phase 1, which is the history taking phase, the clinician does a standard assessment with a special focus for identifying trauma. The large T trauma would be war, fire, assault, rape, etc. Our trauma, a small t, such as being bullied, disrespected, or discriminated. Either the big T or small t trauma can be the focus of EMDR, and it does make one an expert with every traumatized client. If you don't have training working with clients with severe dissociative disorders or with children or older adults, referral to appropriate professionals are in order. So it's important to know where can this person go if this is something that is out of your experience. Phase 2 is preparing them for the EMDR. When a trusting relationship has developed, exclude explanation of how memory of trauma is different from the regular events of one's life. Trauma memories are stored in bits and pieces in an isolated memory network separate from one's life. Memories can seep out of flashbacks or other intrusive memories. Since they are very upsetting, clients avoid persons, places, or things that trigger these memories of trauma. And so they, for example, they might say, if the pain is over, I won't ever let blank ever hurt me again. So if you fill in that blank. This is the core of EMDR, accessing the trauma memories, processing the pain, and resolving the issue. So this is their adaptive information processing, so that they can learn that they are taking the first steps to helping themselves, and that once they can gain control, they'll understand that what they've been through it shouldn't affect them again. And the third phase, it involves exploring with the client that the trauma will be the focus of the desensitization. With a single trauma, the focus is obvious, but those with multiple traumas, deciding where we're going to begin is important. Some want to start with the first memory, others want to start with the worst trauma to start with, and it's important to let the client decide, again, where do you want to start? And it may be wise to start with the less disturbing trauma so that they can start to feel comfortable with the process. Trauma can lead to negative beliefs that are life impairing. They are good targets for EMDR processing. The counselor asks the clients What would you like to believe now after processing it? This should elicit a positive cognition that is more adaptive, such as I'm normal, and some men are users, and some men can be trusted. Maybe using a scale of 1 to 7 for the validity of the cognition, the subject unit of disturbance scale, the SUD scale. Again, I've attached these as handouts, is used to determine the client's level of emotional upset when focusing on the trauma image. 0 means they're not having any disturbance, and 10 could be the worst day of their life. When the clinician asks where they feel the upset in their body, such as a headache, upset stomach, or numbness in the pelvic area, which is common with sexual abuse clients. Phase 4, desensitization of the trauma begins, asking the client to bring the target image to mind while being aware of the negative cognition. This is the NC. After 1 or 2 minutes, bilateral finger movements of processing, they are asked to let it go. Let go of the image, the feelings, the cognition, and the body sensation. They are asked to take a deep breath and go on to the next image, thought or feeling being experienced. And then the next will emerge spontaneously. As each experience is processed, new images will emerge, more upsetting or less so. I encourage patients to let it go. Desensitizing might take 10 minutes or multiple sessions. Desensitizing does not require extended discussion. The client that says very little some may say very little. The client is told before processing starts that if they become overwhelmed, they can raise their hand to take a break. And any trauma work, I always tell them, if you need a break, sometimes you can see that maybe they're wanting to take a break. They may be a little bit agitated, so I'll take a break and let them come back when they're ready. I usually give it about 10 minutes. Phase 5. As target memories are processed, the client shifts to more negative affect and negative cognitions to less upset and less physical disturbance. When the specific unit of disturbance, the SUD scale, is reduced to 0, the client is ready for phase 5. And this is where we begin the installation of a positive cognition. The PC may be the original positive thought identified earlier as the goal of treatment, or it may be an alternative positive cognition that has emerged during the reprocessing. It is important that the PC be valid, such as, I'm stronger now. Don't go over the top, such as, I'll never be hurt again, because we can't guarantee what's going to happen in the near future or, way beyond that time. When the therapist and the client agree on the positive cognition, several sets of eye movements are used to install this positive belief. If it doesn't occur, the client is asked what's blocking them from believing the positive cognition. More are feeling less physical disturbance, and then it is important to focus on relaxing and appreciating the work that's already been done. So letting them know, you've done a lot of work now. So far, this seems to be going really well. Just reassuring them that things are going well. Clients with multiple trauma benefit from 90-minute sessions, which will give them more processing time that they need. Phase 6 is the body scan from Van der Kolk's book called The Body Keep Score. Excellent book, very reasonably cost on Amazon. It's important that when processing traumatic memories, the mind and body are both clear. If the client's body remains tense, painful, or numb, more processing is going to be required. The exception to the rule is the pain might be due to a medical condition. So they might be having migraines or arthritis pain. So being aware of that is also helpful too. Phase 7 is closing the session. Ideally, the client has processed a traumatic memory, has let go of emotional and somatic pain, has embraced a healing positive cognition by the end. It's time to stop, and we'll return to unfinished business at the next session. You want to do a brief relaxation exercise with them, such as progressive muscle relaxation, some relaxing imagery. Sometimes you might want to recall that going to their safe place or safe space. The clinician will explain to the client that additional processing of memories may take place between these sessions. So as they leave, this might trigger them to do some more work on their own. So they are encouraged to keep a TICES log, which is the target image, cognitions, emotions, and sensations between the sessions. The next session will begin with a new target image or return to a previous image if there are unprocessed feelings or thoughts. So if we had to cut them off because of time, we'll stop there and we'll remind them this is where we will pick up when you come back. Okay, we're on to my favorite. And this one I know more about, and the training is extensive, so I did my best to cut this as brief as I could so that you can learn about this new intervention. It is another best practice treatment. It is a cognitive approach for assisting with PTSD. Combines cognitive therapy of Beck with trauma theory of van der Kolk and others. It is found to be an effective treatment for both single trauma as well as those who have been traumatized repeatedly, and can be offered in 12 weekly individual 50-minute sessions, or this can be done in groups. Can't handle CPT. There will be some people who are not good candidates for this, so we need to be mindful of that. And these are clients who are imminently suicidal. Manic clients, not on medications, not ready. When they're stabilized, they can be ready. Psychotic clients who are not stabilized by medications, not ideal. Once they're stabilized, and we know that we can keep them that way for a specific amount of time, then they can begin using this. Substance abuse clients who need to detox before beginning treatment, I often like to have them at least a month or two after they've been clean and sober, because I feel like they have more clarity and ability to understand and participate. Clients at risk in domestic violence situations, so if they're still fearing for their life or worried that their significant other is going to return, they're not ready for it yet. And those that are highly dissociative, these clients are not appropriate for any trauma work until they are stabilized with medication and or safety planning. My voice starts to give out. The focus of CPT is helping clients understand their post-traumatic symptoms. Negative thoughts, I am powerless or I am damaged, that develop during or after the trauma can cause them a lot of pain, such as fear, anxiety, and depression, and contribute to avoidance. I don't want to see my friends now, they wouldn't understand, or some things they might say. In CPT, these are referred to as stuck points. So they literally get stuck in their trauma. In the earlier version, the client was encouraged to write out a detailed description of their trauma. So they had to actually maybe take it as a homework assignment, or maybe we give them that whole session to work on it and be able to review that with them. The current version says that we can give them a choice if they want to write it or not. And either way, if they prefer not to discuss or write about the trauma, the clinician moves to aid the client in identification of the stuck points. So they don't even have to discuss it or even write it. We can just talk about where are they getting stuck. Let's look at that. And CPT without the trauma account is just as effective. So intervening without them sharing anything about it, the research has shown that this is still highly effective. Again, the key issue is choice. They need to feel like they're in control. Giving them choice on how they want to heal gives them a sense of agency. So they feel like they're an active participant in getting themselves better. You might want to use the PTSD checklist while doing this. Again, this is attached to the handouts. They want to get a clear sense of the symptoms the client is currently experiencing is valuable. So actually to be able to see that list is like, okay, yeah, I have that and that. So we let them know that this has come from years of research and working with people with PTSD, and that this is how they were able to create these interventions to help people that need it. Again, I encourage the use of the PTSD checklist that I've attached, and it is in the public domain, so it's not anything you need to buy or get special training in. It is just a good checklist. Even if you're doing a substance abuse evaluation or a mental health evaluation, this is a good tool to use to screen them and see if more help is needed. Maybe they might not even be aware that they're a trauma survivor. And there is a score sheet that can be used to identify the progress over time. So you can use it as the initial assessment, the follow-up assessment, and then there is a weekly version with about 20 questions on it that you can use each time and track their progress as they move. And I always like to tell them I'm very goal-oriented, so I like to see that we're making progress. Being stuck in PTSD. After trauma, clients are often stuck in fear, anger, or panic. Their amygdala, the site of fear or survival, is overactive, and their prefrontal cortex is underactive. They avoid triggers or reminders of the trauma to avoid the accompanying upset. The focus is cognitive to engage the higher functions of the brain to bring the prefrontal cortex back in line. And sharing this rationale is an important part to prepare them for CPT. I'm looking at the time, so I apologize if I get to going a little fast here because I've got a little bit more to go here. So when we talk about being stuck in PTSD, these are the intrusive thoughts that they're experiencing. It's causing arousal. So some of the behaviors they might be dealing with are aggression, self-harm, substance abuse, and as you see there, the list goes on. And number 2 is the brief review. Oh, okay, let's go back. The stuck points are identifying the changes. They can put these in writing, the first session, and write an impact statement about it. So why are they stuck and how is it affecting them? How has it impacted their life? They don't need to be specific about the trauma. They can just talk about the stuck points and focus on their beliefs about the cause and identify changes in their own attitudes about safety, trust, power control, esteem, and intimacy. So those are some areas of their life they might not feel any control over. And so these are what we want to build in the client. The second is the brief review. So they come back. We don't want to say, how was your week? You don't encourage venting about the crisis of the week. This begins with the brief review of the week's symptoms using the PCL attached, shifting quickly to reading the impact statement. Ask the client clarifying questions as I write down the stuck points. So the impact statement may be given as a homework assignment, and you can take time to go over that. And the stuck point log is maintained by both parties. Again, that's attached here for you to use. Stuck points, attributions stemming from the trauma that keep the client from letting go of the pain and moving on. Stuck points include thoughts and not feelings, all or nothing thinking, perceptions rather than facts, and the just world theory as good things happen to good people and bad things happen to bad people. The third session, we will focus on the symptoms on the PCL-5. The SX is my abbreviation for symptoms, and they have the ABC worksheets that are completed during the week. So you'll want to give them like a handful of these so they can do them between sessions. And then you'll explain how changing negative stuck points and thoughts can shift to the feeling of less pain and avoidance. As their beliefs change, their distress and avoidance will be reduced. Sessions 4 and 5. The index event, the traumas faced head on. Some want to write about it, some prefer to skip and focus just on the stuck points, which is perfectly fine. The right approach is the one that the client chooses for themselves. I also encourage them to write in the past tense, like, hey, this is over, this isn't going on now. And then the next session, you want to have them read it out loud so that you can process their emotions together. The ABC worksheets, again, they're attached. If the client doesn't do the written account to focus on the trauma and the most vivid stuck points, you might want to ask, you know, they might want to say, I was drinking, the accident was my fault, I'm damaged, no one can love me. I always get the hind of it, I'll never trust anybody. So these are some examples of statements that they might say, these are stuck points, and you want to work on them. And it's not going to be fast, it's going to be slow. So we want to move to a less negative place before moving to a more healthy place. Step 6, the stuck points work. Continue with the ABC worksheets, and this is sessions 6 through 11. These themes are processed in the CPT work. We are working again. We want them to be safe. They need to feel like they have some trust in the process, that they have some power and control, that their esteem is building, and their intimacy of having relationships with others. We want to help them create some adaptive beliefs to move forward to more adaptive beliefs about themselves. I'm safe, I did not cause the accident or whatever the trauma was, I'm a survivor. Their experiences can be used to help others. Our focus is healing from trauma. The cognitive perspective involves internalizing a sense of value, ability to cope with old and new crises, and letting go of the victim mentality. The clients develop a sense of meaning and willingness to give back through either their parenting, our work, our volunteer efforts. And that's kind of how I got into this business. I've had a lot of trauma in my life, and that's why I got into this work, was wanting to help people. Some books that I recommend. This is on the CPT for PTSD. Very good book. This has been translated into 6 different languages, and it is endorsed by the U.S. Department of Veteran Affairs and Defense. It is good for child abuse, combat, rape, and natural disasters. And this involves an extensive 2-day training. And like I said, I can go on and on about this, but if I could actually do this, it would be something that I could do. Then there's the bottom-up treatment. Here's another book I highly recommend, another very affordable book. You can also get this in audio book for those of you that like to listen to books when you go walking, like I do. Vanderkolk uses CBT with trauma clients. It's called the Body Keep Score. The strategies focus on undoing rage, fear, and helplessness, and carried in the somatic memories of severe trauma survivors. Trauma can result in hyperarousal or periods of numbness, such as being frozen, and severe trauma can result in a child or adult whose brain is less functioning because of rigidity. And if you look at brain scans of people with trauma, you can see the huge difference between somebody who hasn't had any trauma and somebody who's had a trauma. That's what I like about the technology. Some hyperarousal strategies are relaxation, mindfulness, yoga, tai chi, this rhythmic drumming. I can also say we can use this in our sweat lodge, you know, when we use our hand drums to sing songs, or maybe they're learning songs for whatever ceremonies you use. So we can incorporate some culture into this. Those that participate in karate or martial arts, being covered with a heavy weighted blanket. These blankets are so awesome. So if you know somebody who has some PTSD or anxiety, you might want to get them one of these blankets. They're very helpful. Taking a walk, exercise again, getting a pet, working with horses, and some neurofeedback. Some alexithymic strategies would be movement, a lot of the same things, tossing a ball, again, drumming, dancing. You know, some of us like to dance in the powwows, so that is very helpful. mindfulness, massage, maybe some acting in theater, and some sensory motor therapy. This alexithymic, they have a marked dysfunction in emotional awareness. So it's like they're not even aware of some of the problems that they are dealing with. And let's move on to the BNDF. These are brain-derived neurotropic factors. Some trauma survivors show evidence of CNS. This is your central nervous system dysfunction after trauma. They may have an enlarged amygdala, a reduced hippocampus, and a medial prefrontal cortex. They need strategies that promote neuron growth as well as a health of tolerance, telomeres, cell structures that correlate with healthy aging. Some brain-derived neurotropic factors include exercises. Number one is the best thing you can do for any trauma or any mood disorder for that matter. Having positive relationships, getting out in nature, learning to relax, checking our diet and eating healthy. Some might want to weight loss because some might have turned to food as an addiction. And then there are alternative and adjunct treatments. Other research-based treatment option to use with PTSD include prolonged exposure and DBT. Clients with complicated grief will benefit from grief work and prolonged exposure. Other treatments may need. PTSD clients that they might need is anger management, teaching them some executive skills and some psychiatric medication at times. There is an executive skills handout in the handouts that will come with these slides, and that is a response inhibition, task organization, and these are executive skills. This is what maybe we need in the workplace. Working memory, goal-directed persistence, emotional control, learning to sustain your attention, planning, flexibility, learning to be flexible, and metacognition. And I always try to end these with the important message of self-care. Adults with resilience recover more quickly from traumatic experiences. We now know key behaviors we can encourage to foster the development of emotional, social, cognitive, and physical resilience. Effective use of resources facilitates emotional growth. Self-care can enable clinicians, that's us, to have the emotional stamina to offer quality care to clients who may be highly emotional, raging, or suicidal. So if you don't practice self-care, these are the kinds of things, clients that are going to burn you out and cause you some serious health problems if you don't take good care of yourself. And I'm looking at the clock. I just made it to the end. I appreciate all of you taking time out of your busy schedules to be here today and attend this session. It shows that you're interested in helping your people and making a difference in the people's lives that you work with, and giving you some more knowledge of what is out there to help those other people.
Thank you, Avis, very much for putting all of this together. I know how much time you've spent on these webinars, and we appreciate the knowledge you share with all of us. For those of you who are wondering, we will be having another webinar in this series on June 9th at 12 p.m. Central Time. And we will send a follow-up email today with the slideshow presentation, the GIPRA information, and all relevant handouts, and where you can access the recording. So look for that to come soon. And with that, Avis, we want to thank you very, very much. And we look forward to hearing you next month. Thank you.
Next month will be human trafficking. And this was a special request from the audience. So
this was, yes, and our funder. So I appreciate you mentioning that. So we'll look forward to hearing about that. Thank you for all your information. Thanks, guys. Have a good day.